Hello, everyone.
Hello.
Everyone can hear me?
Yes, we can.
Okay. We can start, is it? You can see the slides.
Yes, we can.
Okay. Okay, so we'll do contraception today. Contraception is really an important public health intervention. Some of you might have read the history of contraception, how when it came into effect, there was a lot of quarrels, lots of fights. Women had to march on the streets to say they have the right to take contraception. Doctors called people who wanted to take contraception prostitutes, and they chased them from their consultation rooms. There was a lot of advocacy related to contraception before we got where we are right now. So it has not always been the way it is right now. And there's a lot of advocacy still taking place. If you people listen to the news, I'm sure you've heard about contraception for adolescents as a big issue. At what age can somebody start contraception? That's something that is one of the big issues going on right now. Yeah, so a little bit about the epidemiology. So we have over 200 women in the world who want to use contraception, but they have no access. If you look at the Zambian figures, you'll find that 30% of women who want to use contraception are not able to get it. So they don't want to become pregnant, but there's no way of getting modern contraceptives. Yeah, there are a lot of benefits of contraception. Of course, if pregnancies are very close together, like within 1 year of each other, you'll find that babies are born with low birth weight, they're born small for gestation age, and child mortality increases. So pregnancy spacing is quite important. And people think that would prevent 30% of maternal deaths if we had everyone spacing their pregnancies like 2 years in between. So that's a general feel. So that's like benefits and what's going on in terms of contraception. So you see that even in Zambia, 1 out of 3 women who want contraception have no access to it, which is a big number. You can check these figures in the Zambia Demographic Health Survey book. Yeah, so we know what contraception is. We don't need to talk about that. And I've just defined for you what unmet need for contraception is. It's the percentage of women who want to use contraception but can't use or have no access to contraception. Then fertility awareness methods is a method of contraception. It's what people used to call natural family planning, but now we call it fertility awareness based methods. So that's a nice terminology question for you. Then we have long-acting reversible contraception. In the UK, that is defined as a contraceptive that does not need to be repeated monthly. So you are repeating it when a month has elapsed. But in other countries, I think including us here, we don't define long-acting reversible contraception like that. I think the ones we categorize as long-acting reversible contraception are those that are above 3 months. So for instance, you have your Jadeo. Jadeo is a progesterone-only injectable contraception. It has a chemical in it which is called medroxyprogesterone acetate. So that Jadeo, we inject it every 3 months. So for us, I don't think it qualifies as a long-acting reversible contraception because it's 3 months and below. Then there's another one. We'll look at it in the other slides. It's called Noristerat. I think that one has Noristerat is like a 2-monthly injection. So that one also doesn't qualify as a long-acting reversible contraception in our setup. Then the other terminology to be aware of is efficacy and effectiveness. So efficacy means the way contraception works in ideal situations. In an ideal situation where everyone is following the instructions perfectly, that is what is called efficacy. Effectiveness is how contraception works in the real world. So I can give an example of a condom. So with perfect use of a condom, so you use it every time you have sex, you put it on the way it is described and so on, all the procedures followed. Its efficacy is above 90%. But when you come in the real world with real people, its effectiveness is about, its failure rate goes as high as 24%. When real people use it in real situations. So that's the difference between effectiveness and efficacy. So efficacy is the way a method works in the ideal world. And where we live is not an ideal world. And then effectiveness is how contraception works in the real world, where there are real people. That's effectiveness. And then the other thing you have to be aware of when you read about contraception is these 3 words there. So you have progestins, you have progesterones, and you have progestogens. So you just need to be careful because those words mean different things. So progestogens are these chemicals that are produced from your cholesterol. And they have this baseline ring, pregnenolone ring, I think that's what it's called. But when you say progesterone, you mean a natural progestogen. So something that comes from a plant is extracted from some natural source. So when you say progestin, you mean some progestogen that was made in the lab. It's not natural, it's not extracted from a natural source. So that's about that. Then the last one is the way contraception effectiveness is measured is in 100 women years. So what that means is that if you gave 100 women to use a certain method for 1 year, how many would become pregnant? So that's how contraceptive effectiveness is measured. It's measured in 100 women years. So you give this contraceptive to 100 women and they go through the whole year and see how many have become pregnant after having used that method effectively. So that's what 100 women years means. Okay, so that was about definitions, which we know all of us that are important because we need to speak the same language. We need to be saying what we mean and meaning what we say. So that's why that terminology slide is important. Then the types of contraception that we have, I don't think we need to take long on this slide. We have hormonal, we have non-hormonal, we have surgical methods. We've already defined what a fertility awareness methods means. It's what we used to call natural. And then we have lactation or amenorrhea. So I'll go straight and just say what lactation or amenorrhea is because we won't spend much time on it. So it's a method that somebody who has just delivered can use. The only issue is that they have to breastfeed exclusively. And they have to be within 6 months of delivery, and they don't need to see their menses. So if those three conditions are fulfilled, it means the method is working. If those three parameters there get broken, then it means that method can't be used. A woman needs to use another method or an extra method to back up the breastfeeding. So lactation or amenorrhea is that natural, really, I think, family planning or natural contraception that a woman gets when she's breastfeeding, but it only works well when she's exclusively breastfeeding, she sees no menses, and she's within 6 months of delivery. If she's beyond 6 months, it doesn't work well. If she's seeing a menses, it means it's not working well. And if she's not exclusively breastfeeding, then it cannot, it's not working properly. So that's about lactation or amenorrhea. Then maybe I should also talk about your fertility awareness methods. So for fertility awareness methods, it's really knowing what your cycle is or what the woman's cycle is. And this is an important exam question where you counsel a woman who's maybe a Catholic and they don't want to use any of these drugs that we are going to talk about. So they want you to tell them how to know what are the safe days and so on and so forth. So that's what really fertility awareness method are about. So one way is to take daily temperatures. So a woman takes daily temperatures, and around the time of ovulation, her temperature goes up. It goes up by between 0.2 to 0.5 degrees Celsius. So if she's using a good thermometer, she can detect that increase in temperature and then avoids sexual intercourse around that time. That's one method. The second one is using mucus. So a woman washes her hands and she's following her dates from the first day of menses. She's following her dates, and then she washes her hands and puts her hands around the cervix, and she can see the mucus. If the mucus is watery, not very mucoid, it means that she hasn't ovulated, because after she ovulates, because of the progesterone, the mucus becomes thick and it becomes like it can be stretched like that. So that means that she has ovulated and she can avoid sexual intercourse around that time. Yeah, if she hasn't ovulated, her mucus is clear, it's like egg white. That's what people say. It's like egg white, so she can know that she hasn't ovulated. But around ovulation time, because of the progesterone, the mucus becomes thick and it can be stretched like a string. So then she knows that she has ovulated around that time. Then the last bit there is the issue of ovulation dates. How does she know that these are the safety days? So what people say is that she needs to know her cycle, meaning that she gets a diary of her cycle in 6 months. How long is a cycle? Because every cycle is different. Maybe this cycle is 28 days, the next cycle is 30 days, the other cycle is 27 days, and so on. So she gets the longest cycle and subtracts 10 from it. And she gets the shortest cycle and subtracts 20 from it. So the dates in between those two numbers is the is the time that she's fertile and she should avoid. So if we take somebody who has a 28-day cycle, a perfect 28-day cycle, so it means that their longest cycle is 28 and their shortest cycle is 28. So we subtract 20 from 28, we'll get 18. And we subtract 10 from 28, what do we get? Hello? So we are subtracting 10 and we are subtracting 20 days. So when we subtract 20 from 28, what do we get?
8
days.
We are meaning with 8 days.
What?
8 days.
Okay, then we subtract 10 days from 28.
18. With
18
days.
So it means that between the 8 and the 18 of her cycle, she might be fertile. So she needs to avoid sexual intercourse in those 10 days. Does that make any sense?
No, Doc,
Yes.
it's not clear. No, it's not clear for me.
Okay, so you have a woman with a 28-day cycle,
Yes.
a perfect cycle. So we are using a perfect cycle here to make the calculation. Can we please mute ourselves? We have a 28-day perfect cycle. So the longest cycle means is 28 and the shortest cycle is 28. So you're going to subtract 8 from 28. No, you're going to subtract 10 from 28. We said what you get is what, 18?
Yes.
Yeah, and then we subtract what, 20 from 28. What we get is 8. So a woman's cycle, which is 28 days, it means from the 8 of her cycle to the 18 of her cycle, which is a period of 10 days, she might be ovulating, and she needs to avoid those 10 days in her cycle. So that's how using the dates works. Then lastly, there are what are called ovulation sticks. People with infertility and people with who are trying not to become pregnant can use them. So you do it like a urine test, a pregnancy test. So those sticks, they look for luteinizing hormone in the urine. So after ovulation, we know that luteinizing hormone surges, it goes up. So those sticks are looking for luteinizing hormone, that luteinizing hormone surge. So when you see 2 lines, it means that you are ovulating. And those tests are readily available in many pharmacies. When you see the 2 lines, you know that you are ovulating. So you avoid sex around that time. If you don't see the 2 lines, it means you are not ovulating. So as you can see, these methods are not perfect, and we'll go into that in a few minutes. They're not perfect, and you might end up getting pregnant, of course. So that is about what are called fertility awareness based methods, or what used to be called natural methods. You can use all these things in combination and so on to be more, to make them more effective. Yeah, so that is about that. So we can move from this slide. Yeah, so then we move to the usual drugs that we use for contraception. Most of them are progestogens. So the way progestogens work, they work by making the endometrium thin so that there's no, when the fertilization happens, implantation fails to happen, then they work by thickening the mucus. The same way the natural progesterone that is produced in our body thickens the cervical mucus after ovulation. And then they also work by preventing ovulation at very high doses. At low doses, they work by just thinning, making the endometrium atrophic, and also thickening the cervical mucus. Then we have estrogen and progesterone combination, like the combined oral contraceptive pill. The combined oral contraceptive pill works by inhibiting ovulation. So you give a lot of estrogen and it blocks the production of follicle-stimulating hormone and luteinizing hormone from the pituitary gland. So that blocking, because it's so high, it's telling the estrogen that you've given is communicating to the follicle-stimulating hormone and luteinizing hormone that there's enough estrogen. Don't make the ovary produce more. So because the luteinizing hormone and follicle-stimulating hormone are reduced, then ovulation fails to take place. Then you have your intrauterine contraceptive devices, the ones with coated with hormone, like the levonorgestrel IUCD. It causes thinning of the endometrium. It causes thickening of the mucus. It causes an inflammatory reaction in the endometrium, and this prevents implantation and attachment of the blastocyst in the endometrium, so pregnancy doesn't occur. Because of the inflammation in the endometrium, that inflammation also kills off the sperms. So the sperms don't get to meet the egg, and therefore the pregnancy won't happen. So there's the issue of inflammation, all those inflammatory chemicals, prostaglandins being in the endometrium, blocks the sperms from passing, and so on. In fact, even copper, from the copper IUCD, they say it's spermicidal as well. So all those copper ions in the endometrium prevent sperms from going, because they kill off the sperms. Then of course you have the surgical method, which block, if you have a vasectomy, it will block the sperms from reaching the egg. And if you have a tubal ligation, it will block the sperm from reaching the egg as well. But that patient, of course, continues ovulating, but the sperm does not meet the egg at all. So these are the general mechanisms of action for all these things we are using for contraception. Then contraception is in tiers, in groups. There's tier 1, tier 2, or tier, whatever you pronounce it as, tier 1, tier 2, tier 3. So these groups are according to the effectiveness of these drugs for contraception. So you can see that our tier 1 methods are the ones on top there. So you have your implants, that includes Jadeo, Implanon. Those are the implants are the ones that are put under the skin on the side of the arm. I think we've all seen that. They are put on the side of the arm, and they're just under the skin. You can actually palpate them. If you touch a girl who has an implant on the medial, on the inside part of their arm, you can feel something there. Yeah, it's just under the skin, that rod. That white thing there is like a matchstick. That's the size. Just imagine the size of a matchstick, then you put it under the skin. So we have Implanon, which is putting just one of those. And then we have one type called Jadeo, where you put 2 of them under the skin. So those are the 2 available ones. So these, the ones you see on top are the ones which are called tier 1 or tier 1 methods. So you can see there's vasectomy there, there's sterilization, there's an IUCD there. And you can see the effectiveness on the far right, where they're telling us that if 100 women use these contraceptive methods for 1 year, less than 2 of them would become pregnant. And then you can see the numbers with tier 2 methods, tier 3 methods, and tier 4 methods. So you can see where condoms belong, diaphragms, and so on and so forth. Then your tools there, injectables, lactation, amenorrhea, your oral contraceptive pill, the patch, and the vaginal ring, which we are going to talk about. So this is just to show you that not all contraceptives are the same. They have categories. And what the world is trying to do is to get more women to use the top tier methods. So implants, IUDs, sterilization, vasectomy. That's where most people want most women to use those methods, because those are the most effective methods for various reasons. Yeah, then we have this thing called the medical eligibility criteria. This is the World Health Organization medical eligibility criteria for contraception. So here, all you have to remember is that you have 4 classes: class 1, class 2, class 3, and class 4. So what you need to know is that you are trying to judge conditions. So let's say you have a hypertensive patient. So this patient has hypertension, and you want to use combined oral contraceptive pill on them. So in what category does that method fall with this particular patient? So if it's safe and you can use it in any situation, then it's a category 1. It's a category 1. If the classification is 1. If it's not very good, but the benefits of using that method outweighs the risks, then it's category 2. Then if the risks outweigh the benefits, it's a category 3. If it's don't use, this is a big contraindication, that's a category 4. So it means that when a patient comes in, every patient comes in, especially those with a medical condition, you have to look at the method you are using and look at the medical condition and see where it falls, and then judge if you can use that method according to these categories. So that's how the medical eligibility criteria works. So you look at the condition and you look at the available contraceptives, and then you see where each of the contraceptives according to the condition falls. If someone is on has TB, for instance, and they are on TB drugs, we know that rifampicin activates the enzymes in the liver, and those enzymes in the liver metabolize, cytochrome P450 enzymes. They metabolize the contraception. So the contraception will not be effective in a TB patient who's taking those things. So you need to look at your eligibility criteria and say, is this the best method for this condition? You look through it and see. Or if somebody has deep vein thrombosis, of course, for oral contraceptives, that's a 4. It's contraindicated. If somebody has breast cancer, that condition is category 4 for combined oral contraceptive pill. But if you change the contraception, you say, let's put an implant on, those categories in the middle are going to change. She won't still be category 4 because now you've changed the contraceptive method. She'll be maybe category 2 or category 1, where you say, oh, benefits outweigh the risks, or risks outweigh the benefits or whatever it is, depending on the condition. So this is how medical eligibility works. Yeah, is that clear?
Yes.
Yeah, so that's how medical eligibility works. So for every method, you have to look at your patient. So there's what is called profiling. So you have to profile the patient when they come for contraception. You have to look at, of course, you look at their age, you look at how long they don't want to conceive, and then you look at their medical condition. So for the medical condition part, you use the medical eligibility criteria to decide what you are going to give. What's the safest method to give for this particular patient? Of course, the other things about when they want to become pregnant next time or take into effect. For instance, somebody who wants contraception for only a month, you can't give them an injectable for 3 months. Because we know that if you give somebody Depo-Provera, which is a 3 months contraceptive, it even after you give, it remains in the blood for longer than the 3 months, so that it will prolong the return to fertility for that particular patient. So you need to decide how long does this patient want contraception, and what's their medical condition, and so on. You put all their parameters together, which is what is called profiling, and then you give them a range for your medical conditions, for when you want to become pregnant, for your lifestyle. These are the 4 options you can use. Which one do you want? Like that. That's how normally that is done. So I think we've already talked about the combined hormonal methods. So the combined hormonal methods are actually 3. You have the combined oral contraceptive pill. You have the contraceptive patches, a patch where you just stick it on your arm. You can stick it on your abdomen. You can stick. Can we please mute? Yeah, so the patches, they're like bandages. They are patches. You can put them on the arm. You can put them on the thigh. You can put them on your tummy. And I think these are available as well if you go to the kind of fancy pharmacies, Link and so on. You might find these patches. And then the only place you can't put a patch is the breast, because these have estrogen in it, and estrogen is dangerous because it stimulates breast cells, and there's a risk for breast cancer when you use estrogen-based contraception. So patches, the only place you can't put a patch is a breast. Other parts are the arm, the thigh, the bum, everywhere these patches can be put. And of course, patches are put every week. So there are 7 days things. So you put it this week, next week you change, next week you change. Every 7 days you keep changing. Yeah, and then you have rings. Rings, you see a picture, you just put it around the cervix. It's like a 5 centimeter ring diameter. So it's just put around the cervix and it stays there too. So that's about rings. So you have 3 types of combined hormonal contraceptives that are available: the oral contraceptive pill, the combined hormonal patches, and the combined hormonal rings. I think the other thing I remember on the rings is that the rings have the lowest amount of estrogen in them. So they have the lowest amount of estrogen that a woman is going to get. So that's something about the ring. Yeah, I don't know if there's any questions so far. Yeah, so even for the ring, it's the same. So it's inserted in the around the cervix, and then after 21 days, it gets removed, and then the menses come. Just like the pills, you take a pill every day for 21 days, and after 21 days, the menses come. That's how these methods work. So even the patches, the only difference with the patches is that you are changing the patches every week. And after 21 days, you don't put a patch. And then, yeah, the menses come. Yeah, so that's about these methods. Again, with these methods, you can do what is called tricycling. That's one other terminology that you need to be aware about, what is called tricycling. So it means that you can decide, you can take these methods in such a way that you don't have menses for 3 months. So it means that if you are doing a patch, just keep putting a patch every week for 3 months. Then when you stop at 3 months, the menses come. So there's that provision as well. Even with the combined oral contraceptive pill, you can also tricycle with combined oral contraceptive pill. So you continue taking the pill, the white tablets, the active tablets, until the point at which until 3 months elapses, then the menses come. There's also what is called the tailor. I don't know if the terminology is tailor-made, but it's something tailor method, meaning that it's up to the woman herself who's taking these combined oral contraceptives or combined hormonal contraceptives to decide when she wants to have menses. So she can say 6 months, I'll be taking the tablets every day, and then I won't take the tablets when I decide to have menses. So that's called the tailor-made or whatever, tailoring the way you want. So that's another way, and there's no problem with that. So that's about that. Then you have these progesterone-only methods, which are injectables, implants, and the pills. So we've already talked about the injectables. You have noethisterone and you have medroxyprogesterone acetate. Noethisterone is given every 2 months, and it's not very famous. It's not very, women don't like it a lot, because why should they take the 2 months one when they can do the 3 months one? So the 3 months injection is the Depo-Provera. So Depo-Provera, an injection is given intramuscular. I think it's 150 milligrams intramuscular. And every 3 months, a woman comes to the hospital to get another injection. So it means that in a year, she gets 4 injections. If she takes Noristerat, it means she'll need to take, what is that? Okay, if she takes Depo-Provera, it means it's only three injections, I think. Is it? Mm-hmm. Who's the mathematician? 3 into 12.
4.
Yeah. If you take Noristerat, it's every 2 months. So it means you need 6 injections. Because it's every 2 months, Noristerat. So you need 6 in a year, because a year has 12 months. So if you're taking Depo-Provera, you take 4 injections because it's every 3 months. So that's the difference between Noristerat and Depo-Provera. And these methods, like we said, they work by inhibiting ovulation, but they also have effect on the endometrium, and they also have effect of increasing the thickness of the mucus that is in the cervix, so that the sperms can't go through. Then there's another method. I haven't seen it in Lusaka, but I saw it in the rural area, the cyanopress. So you get, it's the same. It's like Depo-Provera. The active ingredient is medroxyprogesterone acetate, but it's given subcutaneously, just under the skin. So it's easier to administer. People thought that women themselves can administer it the way they administer, like insulin. And also rural healthcare workers can be taught, because it like has an inbuilt already needle, and the needle is short, so it's easy to administer by the patient themselves, or by somebody you don't really need to train properly. Unlike the IM injections. The IM injection, somebody can put a needle in the blood vessel and so on. But these subcutaneous injections are easier. So that's the difference between Depo-Provera and Cyanopress. But they all have medroxyprogesterone acetate. Then we've already talked about implants, Jadel, which is 2 rods, and Implanon, which is 1 rod. And I've put for you there the hormone that is found in Jadel. It's levonorgestrel. I think levonorgestrel is a progestin, just like etonogestrel is a progestin as well. So those are the hormones that are found in these 2 implants. The main problem that women complain about with these progesterone things, injectables and implants, is abnormal bleeding. So some of the patients bleed a lot. Their menses become heavy. Some of them don't bleed at all. But the common side effect is amenorrhea. They stop bleeding. So they stop bleeding, but when they bleed a lot. So 3 months, they don't bleed. And then in the 4th month or 5th month, when they bleed a lot. So those are the main problems. And the other problem with these methods is that even when somebody hasn't taken the injection, sometimes their effect lasts for even a year or so. So that you don't, 6 months to a year, so that you don't want to give. Yeah, so that you don't want to give to somebody who wants a short contraception. They just want it for a month. So you can't give somebody Depo-Provera who wants contraception for just 1 month. Then you have the progesterone-only pill. This one, the difference between a combined oral contraceptive pill and the progesterone-only pill is that for the progesterone-only pill, you take it every day. There's no break. You remember with the combined, you take it for 21 days and you can take a break. When you take a break, you have your menses, and then after 7 days, you start again. But with the progesterone-only pill, there's no break. You have to take it every single day. And and you have to take it at approximately the same time. If it's at 20 hours, you take it at 20 hours all the time. Yeah, so this is the method you can use together with lactation or amenorrhea. If somebody's breastfeeding and they want something light, not a heavy contraceptive, then the progesterone-only pill is what you can give in combination with breastfeeding. So normally somebody's breastfeeding, but you think that they're not breastfeeding enough. So the lactation or amenorrhea method is not going to be perfect. So you can add the progesterone-only pill to that. Because combined oral contraceptive pill in the puparium is a high risk for deep vein thrombosis. So that's why in the puparium, the progesterone-only pill is like a good add-on to breastfeeding, so that you don't get that effect. You don't get that side effect of DVT. And also the combined oral contraceptive pill, I think has some effect on breastfeeding. Yeah, reduces the amount of milk that comes out. So when a woman is breastfeeding, maybe it's not the best contraceptive to use. So that is about progesterone-only pill, your implants, which are Jadeo and Implanon, your injectables, Noristerat and Depo-Provera and Cyanopress. And there's for you the actual ingredients, because that's a common question again that we ask. What is the hormone that you find in Depo-Provera? What is the hormone that is in Jadeo? What is the hormone that is in Implanon? Those are like questions that people ask about. Okay, so then you have your intrauterine devices, the copper IUCD and the levonorgestrel intrauterine system. So we've already said the mechanism of action of these two methods. What you need to remember here is that the main difference between the two IUCDs is that people can we mute please? Yeah, people who use the copper IUCD usually would complain of heavy bleeding and painful menses. People who use levonorgestrel IUCD usually would complain of the difference is that the menses would be lighter if you have levonorgestrel IUCD. And you know that levonorgestrel IUCD has levonorgestrel there, which is being released every day. The copper IUCD has no levonorgestrel. The other difference is that the copper IUCD is used for emergency contraception. The levonorgestrel IUCD is not registered to be used for emergency contraception. The levonorgestrel IUCD is used when you have somebody with painful menses, dysmenorrhea. You can use it if somebody has endometriosis. You can use it as a way to provide progesterone to the endometrium on somebody who's on hormone replacement therapy. So those are some of the other uses you can use the levonorgestrel IUCD for. You just need to remember that you don't use it for emergency contraception. You also need to remember that the copper IUCD is actually the most effective emergency contraception available on the market. So if you want the most effective emergency contraception, it's the copper IUCD. Yeah, it can be inserted within 5 days of intercourse. So that's a big advantage as well. So that's about these two methods. So now just a few pictures of the methods. So let me just go back. No, yeah. So this is a picture of your methods. So I'll start from left going right. So I think you can guess the first one. That's the Cyanopress. I already said that it has an inbuilt needle. All the woman has to do is inject the drug, which you can see there on her thigh somewhere. Yeah, that's it's a subcut. So it's subcutaneous. Then the second one is the copper IUCD. You can see it has copper there and it has 2 arms. And there's a picture on how it kind of fits in the uterus. The next white one is the levonorgestrel IUCD. That thick white thing in the middle is where the drug levonorgestrel is, and it's being released from there every day. Then the last picture you see on your right is somebody trying to insert a Jadeo or an Implanon. So the way these things are inserted, if you haven't seen it before, it's kind of the way we put a cannula, just under the skin. But in this case, you know, when you're putting a cannula, you are removing the stylet out. So now when you remove the you put a cannula, you remove the metal. Then using that tube, you can insert the rod. So the rod, what you do is that you insert like the way you do a cannula. And then after it's under the skin, you remove the stylet, the way you remove it from a cannula. But when you remove it from the cannula, you know the blood starts coming. So through that same place where blood starts coming, you push in a rod back into under the skin. I hope that is clear. That can only be seen properly when you actually see this being done, and you can go to the family planning clinic and that's how that is done. Yeah, then you have your patch there, the patch that we talked about, that you put every week for 21 days. And when you want to have menses, you don't. Yeah, and when you want menses to come, you don't put in the patch. So it's 21 days, but you put every 7 days. And down there, okay, you have your oral contraceptives there, but this is like what I was trying to describe. This is the thing that you are putting under the skin, and you insert the rods through it. This one here. So you insert the rod through the end there, then it goes in once it's pushed under the skin. But like I've said, it's easier to see it when it's being done. For the oral contraceptive pill, the last comment I can make is that you have arrows there on how it's going. And you guys need to remember that you have two types of oral contraceptive pills. You have your monophasic type and you have your phasic type. Your monophasics are the ones where you have the same amount of estrogen throughout. All the tablets have the same amount of estrogen. The ones which are called phasic have different amounts of estrogen in all the tablets. So they are trying to mimic the normal cycle. But with the phasic pills, many patients have abnormal bleeding. So usually the first line is just these monophasic pills where the concentration of estrogen in all the tablets is just the same. So that is about that. So some people can, yes.
I wasn't really getting what you are saying. I think my network was quite bad on my end. Could you kindly repeat on the pictures?
The picture, I was just saying what they are. So the first one is cyanopress. The second one is the copper T or copper 380 thing. Then your third one is the levonorgestrel IUCD. And the last one there is somebody trying to insert a Jadel using the needle that is in your bottom left. So these things, like I said, are put like the way you put a cannula. If you've put a cannula before, you know how you do it. You insert the cannula, then you remove the metal from it, and then blood starts coming out. So in this case, you put something that is like a cannula, but it's under the skin, so there won't be any blood. So once you remove that metal thing from inside, then you just push in this white thing at the bottom left. You push in that white thing until it reaches the end. Then you remove the cannula. Then you've inserted. That's how that is inserted. That's me trying to show you how it's inserted, just to give you a picture, because some of you never go to the family planning clinic. Yeah, but you can go there and see. It's so easy to put. Then on the combined oral contraceptive pill, just know that you take these 21 white tablets. If you are tricycling, like we said, it means that a woman would skip the brown tablets and start in another pack with another white tablet. and finish that pack and finish a third pack like that. It means you are tricycling. So which means that she takes 3 of these white tablets over 3 months without taking the brown ones. So it means that she won't have any periods within that 3 months. And we like to use this for those, yeah. So we use them for those patients who have anemia and maybe due to amenorrhea. So you have controlled the bleeding, but you don't want this woman to keep bleeding. So you keep the menses from happening for 3 months so that they gain their HB. So you can tricycle like that. Or if a woman herself decides that, me, I want to have menses only twice a year, then she can just be taking the white tablets. After 6 months, then she takes the brown ones in that 6th month where she wants periods. And then the menses come like that. So that was about this, this slide. Then the slide on the picture on your left, that's a vaginal ring. This is a combined hormonal vaginal ring. So it's, like I said, it's 54 millimeters. So you just push it around the cervix and it remains there for 21 days. Yeah, and so on. You remove it every 21 days and get another one. If you want periods, you give yourself 1 week, the periods come, then you put another ring after 21 days. That's how the ring works. And of course, we know the female condom there, which is not very popular. We know then there are surgical methods. Again, surgical methods, maybe this is not the correct forum for them, but you just know that we tie the vas deferens or tie the fallopian tubes. We cut, we tie and cut. Usually for a tubal ligation, you need to cut about 1 centimeter of the tube, and you usually need to take it for histopathology so that we are sure that you really cut the tube. And for what you use to tie, you normally use an absorbable suture like chromic. That's what you use to tie there, but I won't go too much into that. Maybe we need a separate discussion for the surgical methods. Yeah, but basically that's that. Then these are some of my last slides. We can mute ourselves. I can hear some sound. So there's a question that is normally asked in your exams, which is that what are the non-contraceptive uses for the combined oral contraception? You need to be careful. You need to differentiate between uses and benefits. Uses means that a patient can come to the hospital to ask for contraception for that method. That's what uses means. So there's no one who comes to the hospital that give me the oral contraceptive pill so that I reduce my risk for cancer, colorectal cancer, or that I reduce my risk for ovarian cancer. No one. So reduction of risk for ovarian cancer is not a use, it's a benefit, it's a side effect. So you need to separate benefits and uses. So uses means that a patient comes with a problem and that problem can be solved by this particular method. So those are the examples of uses: heavy menstrual bleeding, irregular menstrual bleeding. Somebody who's menopausal can have the combined oral contraceptive pill. Somebody who has painful menses can have the oral contraceptive pill. Somebody who needs emergency contraception can have the combined oral contraceptive pill. Only that they have to take 4 tablets, 12 hours apart, if they use the combined oral contraceptive pill, but it can be used for emergency contraception. Then we have the benefits. It reduces the risk of colorectal cancer, reduces the risk of ovarian cancer, it reduces the risk of endometrial cancer, We've already talked about tricycling, and we've already talked about tailored pill use. That's the correct terminology I was looking for. Tailored pill use. So tailored pill use is that we have a girl who wants to have menses every 2 months, not every month. So they take the white tablets there in the corner. Once they reach the 21st day, they get another pack and start over with the white tablets. And then after 2 months, they can have menses. They take those brown tablets there. So that's how that thing works over there. So that's what is called tailored pill use. The woman decides, I want menses every 2 months. I want menses every 4 months. Then she can have take her tablets like that. So I think that's, for me, that's like a benefit of the combined hormonal contraceptives. They have this tailored use kind of thing, because if you have your Depo-Provera, there's no tailored anything. Once it's in your system, it's in your system. You can't say, let me have menses next month. Yeah, so someone wants to ask a question.
Yes, I've got a question.
Yeah.
So you said one of the uses of the combined oral contraceptives is treatment of menopause treatment.
Yes, please.
How is menopause a what can I say, disease or something? Like, why would you want to treat menopause? Indeed, like normal.
Yeah, so that's a big question. Only that I haven't finished my good lecture on menopause. I just did basics. But when somebody's menopausal, after somebody has their last normal menstrual period, because of the reduction in estrogen, a lot of things can happen. They can have reduced bone density. They start having fractures. There are all these things. They can have palpitation. They can start lacking sleep. They can be depressed because there's not enough estrogen being produced. So in the combined oral contraceptive pill, we have both estrogen and progesterone. So we can use it to replace the estrogen in this menopausal woman and give them some progesterone. But I think that's a subject for another day. But basically, that's what it is. I hope that's good enough for now.
I have a question.
Yes.
Is there any? Okay, I've come across some literature which links the long-term use of contraception, hormonal contraceptives, to development of breast cancer. I wanted just to get a comment on that. And then, is there any risk, any health risk associated with a lady starting the use of contraception at an early age, let's say in teen age?
Yeah.
Thank you.
Okay, let's move on to the next slide because the questions are ahead. What's going on with my slides? They're not moving. Okay, so we've already talked about all these things, how combined oral contraceptive works, how we have monophasic and biphasic and phasic pills, and how we need to be aware of drug interactions that happen with a combined oral contraceptive pill. Then we have some contraindications. So if somebody has migraine, you can't give. If somebody has heart disease, coronary heart disease, you can't give. It's if you look at the medical eligibility criteria, the WHO one, the one we looked at, these things are things that are category 4. If you are talking about the combined oral contraceptive pill, because of the estrogen component. So you won't give somebody who has a migraine, you won't give somebody with coronary heart disease, you won't give somebody who has had stroke, you won't give somebody who has had breast cancer, and you won't give somebody who has hypertension. If it's above 160/110, don't even think about it. Yeah, so it's true that combined oral contraceptive pill has a risk for breast cancer. And also that risk is related to the duration of use, yes. Yeah, that's all we can say. But again, you need to go back to the eligibility criteria. What's the benefit versus the risk? Yeah, because you are talking about breast cancer, which might never happen, but you are talking about a teen that will definitely have a baby if they have sex without contraception. So that's what, it's a brilliant question, because that's what eligibility criteria is about. It's about deciding for this particular patient. In this case, you have asked about a teen. What is the best method to use? Yeah, and it's a difficult question to ask, actually. That's why there's a lot of debate about teens and contraception, because there are all these risks. People are even saying there's a risk of cervical cancer if you use the combined oral contraceptive pill. But the debate there is that people who are using the combined oral contraceptive. I'm getting some feedback. What's going on? Yeah, people who are using the combined oral contraceptive pill are also same people who are not using a protection during sex, because that's why they are taking the pill. So are they having cervical cancer because they are not using protection, or are they having cervical cancer because the oral contraceptive pill is a risk for cervical cancer? So there's that debate going on, but the recommendation is that if you have on oral contraceptive pill for a long time, of course, you also need to make sure you are going for cervical cancer screening, just like everyone else. So that's the issue about breast cancer and so on. So your question, really, the answer is that you have to go through the medical eligibility criteria and see what's the best contraception for this teen, because pregnancy is definitely going to happen. And the breast cancer might never happen at all, and so on. So that's a difficult question, but I think that's how I'll answer it. So that's about the risks of contraception for each and everything. Even paracetamol is a risk. We have to measure the risk of taking that drug versus not taking at all. If you don't need it, don't take it. Yeah, then my last slides are on the missed pill, because this is an exam question. So a woman misses one pill, what do you do? A woman misses 2 pills, what do you do? She misses 3 pills, what do you do? She has come for counseling. So for me, the important thing for you to remember is the 7-day rule. And an example will tell us how that works. So you have a patient who takes their pill at midnight, every midnight, because they have side effects. So they want to take it when they're about to sleep. So they take their pill at midnight all the time. So now it's a Friday. So they go to Chicago's at 18 hours, and midnight has passed. They haven't taken the pill. Then it's 11 hours now. They wake up from their bed at lunchtime and realize that, oh, I didn't take the pill. I didn't take the pill at midnight. So it's only 1 pill. So they can just take that particular pill, and when they have remembered, and take the next pill at midnight as usual. Because the pill has been missed within 24 to 48 hours. So you need to remember 24 to 48 hours, within 24 to 48 hours. Then the next caveat there is that, have they taken the oral contraceptive pill consistently the last 7 days? if they've taken it consistently the last 7 days before missing this one pill, then just taking the pill at the time they remember and continuing at the next midnight is more than enough. It's okay. This particular patient doesn't need emergency contraception. But if this person hasn't taken contraception continuously the last previous 7 days, then they need to add some emergency contraception, one, or abstain. Yeah, so that's what they need to do. They need to take emergency contraception, abstain, but they also need to take that pill that they missed at that particular time. Second scenario, they miss the pill at midnight, but then it's midnight again. Then they remember the other midnight. So there's midnight when they were at Chicago's, and then there's the next midnight. Now that's when they realize that, no, it's midnight now, I need to take my pill. But even the previous midnight, I didn't take. So for this particular person, again, they just have to take their 2 tablets and move on. They move on if the last 7 days they've been taking the tablets consistently. If they haven't been taking their tablets consistently, it's midnight now. They've missed almost 2 tablets, but it's within 48 hours. So it means they take their 2 tablets and they'll be on some condoms or abstinence or some emergency contraception for a period until they've taken the pill for another 7 days. That's when the effect comes back. So that's about missing the pill. For within 48 hours. If you've missed the pill and it's more than 48 hours, then really you need your condoms, you need your emergency contraception, you need to abstain in that period. That's the safest way to go. And that's the easiest way I can present for you what to do with the missed pill. So if you've gone beyond 48 hours, it means you take 1 tablet when you've remembered. Now you're beyond 48 hours. You take the tablet, 1 tablet when you remember. Then in our scenario, at midnight, you take the tablet that you are supposed to take and the one you missed. And then you move on. But it means that you need some backup, which is condoms, abstinence, or emergency contraception in that period, depending on the circumstances. So that is about the missed pill. There are other complications, which are like, have you missed the pill in the first week of your combined oral contraceptive pill? Have you missed the pill in the last week? And so on. Yeah, but the important thing is that once you miss the pill and you haven't taken the pill properly the last 7 days, it means that your protection only comes back after you've taken tablets consistently for 7 days. That's like the big thing about emergency contraception. You need 7 days to have the effect of your contraception at its peak. Yeah, so if you miss a pill, it means that you need 7 days to regain the effectiveness. So if you are in the 3rd week, it means that you have to skip the brown ones and go straight to another white one, because you are in the last week now and you've missed your tablet in the last week. It means that you can't be taking the brown ones because you've lost your your effect of the contraception for 7 days. So you need to restart. After 7 days, that's when the effectiveness of your contraception comes back. So that's about the 7-day rule. So just think about 7 days, 7 days, 7 days. The previous 7 days and the coming 7 days. What is happening now? Because now you've missed the pill in this week under discussion. So that can be a bit confusing, but I hope I haven't confused anyone more. Then emergency contraception. Hello?
I'm not clear on the days rule. Can you please repeat what you said?
The 7 days rule just means that if you miss a pill, you have no protection for 7 days. Unless you've missed the pill within, the time of missing your pill is within less than 48 hours. Maybe your effect is still there. And you might not need emergency contraception. Unless you didn't take your tablets the previous 7 days properly. So the 7-day rule states that the effectiveness of your oral contraceptive pill is based on the fact that you've been taking your tablet consistently for the last 7 days. So if your previous 7 days were not okay, it means you are not safe today. And if you miss your pill today, it means that the next 7 days are not safe until you have consistently taken your tablets for 7 days. Then your effectiveness comes back. Really, that's what the 7-day rule is about. That's clear, isn't it?
Yes, it is.
Yeah. So that's the 7-day rule. Then emergency contraception, we all know. So if you are taking the oral contraceptive pill, it's the usual within 72 hours, you get 4 tablets, and the other tablets after 12 hours, 4 now and 12 hours later. If you're using the IUCD, which is the copper, within 5 days, you can insert it. Because we know the implantation of the blastocyst takes place 6 days after fertilization. So it means that within 6 days of the sex, you can actually insert an IUCD. Levonorgestrel, we don't use. IUCD is not used for emergency contraception. And we have the levonorgestrel pill. That's the Plan B, the common pill that we buy from the shops. So we have one that you can take twice, 12 hours apart, 1 tablet. And we have another one, I think it's 1.5 milligrams that you take just once, 1 tablet. Yeah, so that's about
okay, listen, just leave it out. Just drill it. But you can put even before.
Can we mute? Yeah, so that's about emergency contraception. Yeah, so the hormone in the emergency contraception is levonorgestrel. That's also something you need to know. That's about that. So this one, we don't need to go too much in it. All we need to know is that emergency contraception is not as effective as regular contraception. I think it's only the copper IUCD that has like 99% effectiveness for emergency contraception. Everything else is like 60 to 75% effective. But I guess 60 to 75 is better than 0. Yeah. Then what's the future for contraception? There are 2 things: contraception with less side effects for women, We see how we are talking about cervical cancer, breast cancer, deep vein thrombosis, all those risks. And then there's need to have better contraception for men. Yeah, so I can tell you a story about a young boy who committed suicide after making a young girl pregnant. We know from what we've discussed that with typical use, the failure rate for condoms is around 24%, which is really high. So it means that on the men's side, there are only 2 types of contraception that are effective, that can be used. You have your vasectomy and you have your the condoms. The only thing you have is the color. That's the variety in the amount of contraception men can take. And I think that if that boy had options, if he had a tablet he could take when visiting that girl, I think he would have taken it. Only that that tablet doesn't exist. So I think that's the future for contraception for you people are scientists finding something effective for men, tablets especially, or an injection even, that works properly. Yeah, so that's about the future. Then lastly, this is a question from one of your exams. And I think that all of us can now answer this question without problems, easily. Yeah, so I think that was that. We can't say everything, we can't talk about everything, otherwise we'd be here for 2 days. And as you've seen, we've been here for almost 1 hour, 30 minutes, which is too long, but it's a broad topic. And I just thought I try and cover as much as possible. There's a question?
Yes, Doc, I have a question.
Yes.
Yes, how about the withdrawal method? Are you able to say anything about that?
It doesn't work. That's what I'll say. Don't withdraw anything, just use proper contraception. It doesn't work. The reason it doesn't work is that before ejaculation, some sperms swim out still. So the ejaculation point is the point where the highest number of sperms come out. It doesn't mean that when you haven't ejaculated, the sperms haven't gone in, no. So that's why it doesn't work. So withdrawal is even too late now. Yeah, so that's the thing. Okay, any other question?
Dr. Shanzi, I wanted to find out what we are starting with tomorrow. Are we starting with OBS or GYN, and is it true or false or MCQ?
You people, I've already said that no one likes true and false. The lecturers don't like it and the students don't like it. So it's been abolished. We don't do true false. Then I don't know what you start with. You need to ask Dr. Chimana, but paper 1 is OBS, paper 2 is GYN. Yeah, so I don't know what you decide to start with, but paper 1 is OBS, paper 2 is GYN. Yeah, that's all I can say. Any other issues? Any other issues? Hello, can somebody say there are no other issues?
There are no other issues.
No issues.
Nothing.
Okay.
Thank you.
Thank you. Good luck in your exams.
Thank you.